Okay, so the next thing I'm going to demonstrate is the concept of punch biopsy. So we have a patient here who has this blue macule, and the concept of punch biopsy is we're going beyond the surface of the skin, literally through all of the epidermis, all the layers of the dermis, and down to the subcutaneous fat. So the patient's been consented. We're going to go ahead and clean with rubbing alcohol. And I'll note that frequently in a biopsy situation, we will do this as I'm going to do right now as aseptic technique. If this is a much larger punch, then some folks may actually do this as sterile technique. We're going to go ahead and clean with rubbing alcohol to start with. And as anesthesia tends to distort the skin, I'm going to go ahead and just kind of mark with my surgical pen here all around the borders. And now we're going to get the area anesthetized. And this is lidocaine that has been buffered with sodium bicarb and a little epinephrine. And I'm going to be numbing the area here, bevel side up. We're trying to create a wheel. And I might go just even a little bit broader than the area that's marked, anticipating that following punch, I'll be closing this with suture. And so we're going to need sort of that lateral breath to make sure that the patient stays comfortable. So applying a little tension to the skin, going at about a 45-degree angle, kind of sharp poke going in. And again, this skin is just a little more resistant than human skin tends to be. This feels a little bit more like what the bottom of somebody's plantar surface would be like. But I am kind of feeling that distension in the skin. And generally, if patients have discomfort during anesthesia, that's really where more of that's coming from, especially with a buffered lidocaine, which fixes that pH problem that normally makes patients uncomfortable. But just that distension initially would kind of cause some increased discomfort. Going slow, can kind of do a little distraction technique if need be. I'm going to just make sure the other side here is numbed up. Good, we're going to call that done. So punch biopsy tool looks kind of like this. They come in varying sizes. Typically they're round. There are some that are more elliptical. And in real life this would already be open and kind of set up on my clean tray. But this is what it looks like. You can see there's a plastic phalange. Patients constantly ask, how do you know how deep to go? The concept is we're going full skin thickness, but the phalange will stop us. The reality is you do have to use a little bit of downward force to get this through the skin. And if anyone's ever tried to close something that's completely annular or circular, it is hard to bring those edges together in sort of a cosmetically nice fashion. So ellipses do better. And to kind of create an elliptical scenario, I am going to kind of do a sort of widespread tension on the skin. We're going to try to kind of be pulling the skin taut so that after I've performed the punch and release it, we have a more elliptical shape. And that's just going to aid in closure. So I'm going to use the tool right over my marked lesion and literally at 90 degrees just sort of twist. Some pressure and a twist, the phalange stops me there. You can now see that that specimen is in the skin. And this is one of the most critical parts of punch biopsy or punch excision is we actually want to make sure we're removing the entire layers of skin. So I'm pulling up here with my forceps and I'm showing myself the base of the specimen and I'm looking for subcutaneous fat. This is a little bit easier on human skin, but there is a layer of subcutaneous fat here at the base. And basically we're going to use our tissue scissors to sort of separate that from the base of the specimen. So ultimately you get a plug kind of like this. Now when we do this in human beings, because the subcutaneous fat and sort of a fresh specimen is very yellow, and so you'll kind of see the surface part of the lesion where my blue ink is, kind of the epidermis into the dermis, and just a little bit of the subcutaneous. But this is kind of a nice generous specimen. This would go into a pathology bottle and get sent out. Technically, small defects like this can be left to be closed by secondary intention, meaning let it granulate in on its own. But for most patients, we can achieve better hemostasis and a better cosmetic outcome if we close it. So I'm going to just use some 4-0 nylon suture, kind of loading onto the needle driver here. And basic concept is doing interrupted suturing. picking up the skin, kind of showing yourself the edge, and we're going to go in at a 90 degree. So again, we're not holding the ring in our hands, I'm holding the tool kind of in my palm, and the concept being that the needle driver is just an extension of my hand. And I'm going to use just sort of a nice single sweeping movement here to take one bite if I can. It just keeps things a little bit better approximated. And then just doing an instrument tie here. And I wasn't able to achieve the best elliptical defect here with the sort of tension of this pig skin, but the concept is definitely there. Aesthetically, I don't like doing punches larger than 8 millimeter because I think aesthetically it really kind of gets away from being able to close things nicely. If a lesion sort of warrants something larger than an 8 millimeter punch, I kind of prefer just to plan for sort of just wide elliptical excision. And so we'd continue like that, and then kind of course, just trimming our suture here. And given the size of the specimen, you know, one suture is probably adequate for sort of maintaining hemostasis here. In more pliable skin, you know, we may kind of see that cosmetically look a little bit better, but this is kind of the concept of punch biopsy.